It is my pleasure to welcome everybody back from lunch to kick off what I know is going to be a very informative afternoon. I'm Chad Shearer, Senior Vice President for Policy and Program at UHF. And before we get started, I just really want to reiterate our profound thanks to Essentra Health for sponsoring our lunch today. We'll just reflect a little bit on kind of how we got to where we're at with this panel today. As we thought about the agenda for this conference, starting back in January, obviously there was a lot going on in Medicaid, but I don't think we thought we'd necessarily be exactly where we are today. We thought we might be getting by with, a full celebration of Medicaid at 60. And, fortunately or unfortunately, we've had to shift a little bit. But I think the best thing that happened in our shifting of the agenda this year was that we decided to dedicate a whole panel as opposed to just a section of Amir's keynote on the 1115 waiver and hear directly from the state staff that are guiding implementation. And fortunately for me, I end up with the best job of the day out of this, which is moderating this amazing panel. What I hope we all leave here with by the end of this discussion is a better sense of the amount of progress that has been made in what is a very short period of time when you think about waiver timelines. And that's so much work that has been done, but the reality is there's so much work left to do and time remains enemy number one. I think it's important to leave here understanding kind of the sheer number of partnerships that are required to support the success of the waiver, and just thinking about how many individual connections that is across a state the size of New York. And many of those are already in place, but there is much more to be done in terms of developing those partnerships in a way that serves the needs of Medicaid beneficiaries. And just recognizing the reality of the waiver amendment this short, you have to start thinking about the future, probably even before it starts. And I know we were thinking about the future even before it started. I know this group of people has been thinking about the future even before it started. And so we want to take a little bit of time to talk about kind of what is the path forward, recognizing the end of the waiver is near. So everybody across the ecosystem has been working really day and night to put these pieces in place to better integrate physical, behavioral, and social care under the waiver. The staff at the state, I promise you, has been working especially hard, and it's my honor to be joined by three of the most dedicated public servants you will find. I find that they spend most of their waking hours, including sometimes on email trails with me, and I think they must spend some part of their sleeping hours as well doing this work because it's impossible to see all that they get done and see how laser focused they are on improving health for nearly 7 million New Yorkers supported by Medicaid. You can find their bios on our website, and many of you know them well already. But for our audience members that don't have the pleasure of interacting with them like some of us do, I thought it'd be great to start just with each of you telling our audience a little bit about yourself, your big picture role in Medicaid, and then more specifically, your role in the waiver. So Amanda, you want to start?
Sure. Good afternoon, everyone. Great to be with you. I'm Amanda Lothrop. I am the Medicaid Chief Operating Officer. My background is in consulting before coming over to the state a few years ago, and now I spend my time really focused on helping our organization within Medicaid and helping all of you make it as easy as possible for you to engage with the Medicaid program and deliver these really important services to Medicaid members.
Hi, everybody. Happy to be with you here this afternoon. My name is Selena Hajiani. I am the Director of Strategic Operations and Planning for the New York Medicaid program. Prior to this, I worked for the New York State Assembly Ways and Means Committee for nearly a decade. Coming here, I oversee our waiver management and project management teams. I've had the pleasure or difficulty, depending on how you look at it, of getting to see the New York Health Equity Amendment from start to finish. It was one of the first projects that I took on when I started with the department, when we were sort of trying to figure out what is the next phase of our waiver and the Medicaid program, through negotiations and to implementation today. So excited to talk to you all about our progress.
Hi, everyone. Emily Engel. I'm the director for the Bureau of Social Care and Community Supports. I've been with the department for 12 years now. Started with the Medicaid Redesign Team Supportive Housing Initiative and really grew from there. And our Bureau's goal is integrating social care in the Medicaid program. So when the waiver came along, it was like a perfect fit of how do we really integrate social care in the Medicaid program, expand these services for Medicaid members. And that is me.
Great. So I want to start, with the first P of the three, the progress that's been made to date. And I think it's really hard for any of us to believe that we're almost at the midpoint of the 39-month waiver amendment. And for those of you that aren't in the audience that maybe aren't following this day to day, can you all just take a few minutes to talk about just all that's been done over the last 19 months and more before that to get us to where we're at today?
Yeah, it has taken a lot of work and effort from our team, from our partners in state government, from stakeholders like you all. And it's been a big effort, and it's been great to see this collaboration and partnership come together and has really brought us to where we are today. Oh, apologies. Is this better? The past 19 months we had our waiver amendment approved in January of 2024. The past 19 months have been insane, great, exhausting, exciting, interesting. We, like Chad mentioned, our enemy number one is time, right? We got maybe 54% of the time that we requested. We wanted 6 years. We got 3 years and change. But our focus really has been maximizing the benefits for our members, for the delivery system, and really taking this opportunity and running with it as fast and as hard as we can as a group and as a team. And, we're very lucky to have our waiver entities, the social care networks and the workforce investment organizations running right alongside with us, as well as their partners, the healthcare organizations, the behavioral health providers, the MCOs, the CVOs, and everyone. And it's incredible to see the dedication to this work and how everyone is finding creative solutions as we all sort of figure out how to work in this space. We don't have the time, right? So we're kind of building the plane as we're flying it and making adjustments along the way. But it's more than just a race, right? To build lasting change, it requires endurance. And we are really focused on building an infrastructure that can last well beyond the demonstration period and that can really make significant strides to achieving whole person care for our Medicaid members. And so just to give like a very brief update on where the programs are, and we'll get into more detail as we go through our discussion here today. Our social care networks had launched in January of this year. There's coverage for every service except for medical respite, which we're working on rolling out. The Career Pathways Training Program has been up and running since September of this year. I think we have approximately 4,500 participants and counting. And we're just graduating our first cohort. They're going through the licensure process, and that has been incredible to see. And we're about to do a big push for this coming semester, which I'll talk about a little bit more later. We're ramping up our student loan repayment program. We also have our patient-centered medical home incentive, which is not authorized through the waiver, but is tied to all of this work and enables and requires those participating in that program to partner with the social care network, sort of adding to that synergy of these programs. And then finally, the continuous eligibility for children up to age 6, as was mentioned earlier today. CMS is discontinuing that policy through 1115 waivers, but there has been a lot of work that has gone into standing up that component of the Medicaid program as well.
So let's dig in a little bit more on a couple of those components. Emily, on the social care networks, I think folks generally know, they're up and running. Screenings and assessments and referrals and services are starting to take place. But can you just go a little deeper on what it's taken to get the SCNs to that point and kind of what their current capacity looks like?
Yeah. I think, when we do this work, people think like you turn on a switch and you just screen people and connect them to services. And it's like this easy process. And I think we all wish it was like that, but it's not. There's a lot of infrastructure that had to be built. So, there are data workflows and coding, right? To make sure that services are delivered and that we can track them and give evaluation and results. The social care networks have poured like blood, and I'm looking at them because they're kind of centered over here, blood, sweat, and tears in their staff into, building and onboarding and training their partners so that they can, outreach to Medicaid members and get screenings and connect them to those services through the waiver. So, like Selena mentioned, our timetable is squished, right? We didn't have a planning year, right? There was no, we're planning and implementing at the same time, and kind of like pushing the boulder up the hill for implementation. But we've gotten to a place where, we have full networks. We're able to provide, SCN services. The social care network lead entities are still recruiting new providers, new partners, new CBOs to join the networks and serve more members. And now they're starting their marketing outreach efforts, which is really exciting. It's been a rapid race, but and there's been a lot that goes into, just the workflows and being able to deliver services. But it's been an exciting journey. I think they would all agree, in one that's really taken off at this point.
Selena, you talked a little bit about the workforce investment organizations and the career pathways training program and the student loan repayment program. Can you talk a little bit about kind of the importance of those components of the waiver and where things sit on both of those?
Absolutely. Yeah. So, the Career Pathways Training Program and the Student Loan Repayment Program were designed to address high demand titles in the New York State health and related workforce. And they were intended also to help support social care network ramp up with the inclusion of community health workers and patient care managers. It covers titles including nursing, social work. There are 13 titles in total. I won't list them all to you. But the CPT program is essentially a comprehensive program that is intended to support participants from start to finish, from, helping to decide, what career might be right for them, what programs might be right for them, to getting them enrolled in the schools, providing academic support, career training and support, benefits navigation, should they need to be connected to benefits, support for books and lab supplies. We really try to be comprehensive here, and then also into licensing, and actually finding a job. The WIOs are doing, incredible work, and we're hearing that people are really sort of loving this level of support. The participants will have to make a 3-year commitment to working for a Medicaid provider that serves at least 30% Medicaid and or uninsured individuals, or they're part of the social care networks, or they are a social care network lead entity. But, we're really excited, like I said, to be graduating our first cohort. We have until March of 2027 for this program. And as some of you may know, some of these titles take, quite some time for the programming, et cetera. So this fall really is our last chance for some of the longer term academic programs. So, really encourage folks to talk to their regional workforce investment organizations and either, as a provider interested in upskilling your staff or as an individual interested in advancing in your career. I think this is a really unique and great opportunity that we have to support the New York State workforce. So really encourage folks to jump into this. And for the student loan repayment program, like I mentioned, we are ramping that up. We will post the application and additional information on our website. So please sign up for our MRT listserv. Follow us on social media, and we will be providing additional information there.
So pulling the nose of the plane up just a touch, Amanda, you obviously have amazing people working on the operations every day, thinking about achieving the ultimate outcomes. But how are you at kind of the COO level thinking about interim measures of success in terms of the internal operations and making sure that, staff is helping the field get ideally positioned to meet the long-term outcomes of the waiver?
Yeah, thanks, Chad. I think one of the behind the scenes things that has been going on that you've not really been able to dig into with us yet is that we've stood up a deep data infrastructure tied to this effort. So our goal here in sustainability that Emily was referencing is the ability to make data-driven decisions along the way and really see and feel those results. So there's a push and pull tied to that. Some of it's data that we've got incoming, and there's a little bit of a learning curve of how do we pair that together and really understand and appreciate it. But that enables us to see the progress as it's happening. We can see the screenings and services being delivered. We can see where the gaps may be. We can feel out and really get a heat map of the state and where are their needs and where are their gaps and how do we best support people. That also is a channel of feedback from you all. And so we'd love to hear how we can best serve you. What is it that you need to be able to meet the needs of your members where they are? And I think we've got both of those channels up and going, and that's really how we can see and feel the effects of what we're doing. Despite the halfway point, we're still in the early days of doing this. So I think we're feeling out a lot of that data right now and being able to get to a point of making decisions based on it. But that's what's going to enable both the success in terms of monitoring your experience, monitoring member experience, monitoring the penetration and footprint that we're able to accomplish, but then also monitoring and building that sustainability pathway to keep this going well into the future. You don't build an infrastructure like we have if you're planning to do this for 2 years. There's no point. There's no point in putting all of that effort in if this is a quick bang, we're done. This was built very intentionally to last well beyond what this waiver period is.
Yeah, and we'll definitely come back to that path forward at the end, but want to talk a little bit about kind of some of the realities that were discussed this morning. And obviously this waiver work is not happening in a vacuum. There are broader kind of darker clouds on the horizon. I find myself struggling with this, and I assume others in the room do as well. Like, how do you hold together kind of nearly two polar opposite truths at once, that all this waiver work is happening and it's exciting and we're moving forward with it all the time? Well, I assume your time and effort is also being pulled towards what's coming out of Washington and, what are the realities of what our future is going to look like, even though we know we've got to keep moving forward on the waiver, at light speed. So how do you guys deal with that on a day-to-day basis?
Yeah, there's some of this that's just disheartening. This team put so much work into continuous eligibility for children ages 0 to 6. That is an evidence-driven decision. That's the core of the program. There's no world in which you can convince any of us that it's a good decision to eliminate that process. So you've got big changes like that just are really hard. But at the same time, I think what we anchor ourselves on is that the changes that we're able to drive through the social care networks and the workforce investment organizations is really that path of here's how we can get help to those who need it. And there are even more people who need help now with the changes coming in. So these are real impacts that we can have today and going forward in really driving home impacting the lives of those people who need it. And I think that's it's rough to rough to do anything other than focus on the outcome that we can achieve here. Because you're right, it's a hard time.
Great. So let's talk a little bit about partnerships. And obviously one of the key partnerships underpinning the success of the waiver is the partnership between the social care network lead entities and the CBOs in their networks. How was it that the SCN program was really designed to foster these important partnerships and allow them to grow?
Yeah. So, from early days, right, we know that HRSN services are effective, and we were thinking like during value-based payment, when we had those requirements, right, for plans to contract with a community-based organization and to do a social care intervention, we had VBP boot camps. Sorry about that. And, all that, kind of build up, right? And it was effective in that we saw, partnerships forming and really good work of like Medicaid members getting things like medically tailored meals, right? And we were like, we need to scale that. And we saw, some early adopters like Healthy Alliance, Staten Island Performing Provider System, Healy, that were starting to like bring together community-based organizations. We're like, that's really cool. Like we need to like scale that, right? That's how this work gets done, is like building these hubs and creating real partnerships with the managed care organizations and the hospitals and behavioral health providers, and really getting that community reach through the community-based organization and the boots on the ground. And so we created these social care networks with the goal of having that community reach, but also just like being able to take that administrative function for the community-based organizations of like having to deal with the payments and contracting, right? We wanted to make this like really low barrier for community-based organizations to participate, but also for providers. We know that Medicaid members, yes, they're going to their food pantry and can get connected into, social care networks there, but like in the emergency room or their provider office, like that it should be really an open door and easy for Medicaid members to access. So everything in the design of the waiver of the social care networks was thought through like the Medicaid member lens of like ease of process, right? Ease of connecting into services. We have a, 12 question screening tool. It's the same no matter where you go, so that they can get access to those services. And so, I think the social care networks take that administrative burden of, from community-based organizations, but also, being that connector and making sure that, that is an easy barrier for Medicaid members to access the services.
Well, I'm going to go a touch off script here because you just raised something that aligned with something that Selena said that I want to get your take on. Obviously, one of the areas of focus has been, to your point, Emily, is getting healthcare providers engaged in some of these partnerships, and there are some carrots out there in terms of the PCMH incentive. So, can you talk about kind of how that's played into building those partnerships between the social care networks and the healthcare providers? Anybody?
So sure, I can talk about that. Yes, so we have the PCMH enhancement that, in order to receive that enhancement, you must partner with the SCNs, whether that's screening and navigating on behalf of the SCN, or just making referrals to the SCN and making those sort of warm handoff connections. We've also integrated this into our Medicaid Hospital Global Budget Initiative and requiring those waiver hospitals hospitals to partner and contract with the SCNs for screening and potentially navigation and other services. We're really sort of encouraging folks across the board and, really trying to highlight the benefits in terms of increasing access to care and health outcomes, and even working with our partners at the Office for Children and Family Services and others, focusing on the foster care population, those leaving juvenile justice settings, really trying to make those connections and show the benefits of how this can help people be reunited with or children be reunited with their families, or to live safely in the community. And I think we've really gotten great reception and interest and participation through all of this.
I think also on the provider side, since you brought it up, not to go off script,
Yes.
we want to make it low barrier for providers as well, and worked a lot on interoperability. So the nice thing about our state data infrastructure is that providers are screening through their EHR systems, and that's getting sent through their regional qualified entity and routed to the correct social care network, and they can get paid for those screenings. And I like to, point that out because that's a very unique to New York data infrastructure. And I think, it's something we worked really hard on because, again, reaching Medicaid members where they are, as providers, we all want Medicaid members to, reach those evidence-based services of, nutrition and housing. And so by, screening and having EHR connectivity, or using the apps in the EHR system, we have a huge chart online if you really want to dive into it, and being able to get paid for those screenings too. So it's not just sending the screens, but being able to get paid for those screenings is kind of another important part of the waiver.
Yeah, and as we remain in the partnership bucket, the amount of partnership that has been required to create that data IT infrastructure is extremely impressive if you've even been on the edges of it, like we've been lucky enough to. So kudos to everybody that's been a big part of making that data IT infrastructure work and the partnerships required to do so. As we move towards Q&A, please get your questions ready, both online and in the audience. I want to talk a little bit about kind of where from here and what the path forward looks like. One thing that I wanted to achieve today was to remind everybody that, by definition, 1115 waivers are demonstrations. They're meant to test bold new ideas and how does, what we've set up here with the SCN program support not just a bold new idea, but also the underlying goals of Medicaid in improving prevention, managing costs, improving overall health outcomes? Because I think as we move towards kind of what would it take to make social care networks kind of a lasting part of Medicaid going forward, Amanda, to your point, those are kind of the questions we need to answer. How do these things reinforce the broader goals of the program?
I mean, I can start, and feel free to chime in. I think when you think about the how you embed this into a lasting impact, part of it is just, you can see the natural evolution. It's not like health-related social needs is a new concept. I think it's fairly well understood that addressing people's health-related social needs improves their lives. And that's a very, very intuitive concept. I think what we've now built at a scale that's not been seen before, really anywhere in the country, is the ability to do that for a very large population. And part of the waiver is testing what is the right fit for the right population and the right set of services to make the biggest impact that not only improves lives, but has that downstream ROI. Like, can you see it in quality of care, quality of medical intervention, quality of satisfaction of life? Can you see it in the cost of services being delivered? It should absolutely be true that for some of the population receiving this, if not a very large portion that we'll see through the data, that you will have lower medical reduced medical needs and lower clinical care costs as a result of having health-related social needs addressed. And so that's the sustainability point that you can just see has been part of the system to date. Once it's embedded there today, it's hard to see how you take that away. Why would you want to when you see that everything that you're doing today is improved by the introduction of addressing nutrition needs that someone has, addressing housing needs, being able to support their ability to get the care and services that they require.
Great. So thinking about kind of the logistics of the path forward and this weird reality that we're in this unique period of time. Our current waiver requires a renewal submission relatively early next year, Q2 next year. How do you think about the reality of having to submit a renewal, given where we're at and what's coming at us from the feds?
Yeah, it's actually Q1 of next
Oh,
year.
Q1, sorry. It's due on the 31st of March, not the 1st of April. That's
Right.
correct. Sorry, my bad.
It's rough to be doing this so soon, to have to think about what is next and what does this look like for the future while you're still building up. But we are interested in maintaining these programs. We wanted to try to maintain all of them, but as we mentioned, CMS has, expressed disinterest in continuing workforce programming through the 1115 and continuous eligibility. But we will include the HRSN services, including both housing and nutrition, in our renewal application. Our 1115 waiver is much bigger than just NYHER. It authorizes our managed care programming, specialized services for those with substance use disorder and serious mental illness as well. So we will work to, as part of our request, we will work to maintain everything as it is. And we will then start negotiations with CMS.
I think maybe to build on that, part of this is our problem with the renewal. Like there are going to be some wonky technicalities that will have to look different because of a change in federal administration or policy direction. But our job is to have this look and feel as close to current state for you all as possible. This will continue in some capacity. There's a reason that we built it the way that we did, so that we have multiple avenues of federal technical pathways to pursue to get it to look and feel the same way it does right now for you to continue to run and really integrate with the social care networks as much as possible right now, impact as many members as you can right now.
So I'm going to go to one of the questions because I think it fits so perfectly with what you just said, Amanda. Thinking about those different federal pathways, how are you thinking about the funding mechanisms in a next waiver, given the guidance that has, even if it's sub-regulatory, that has come down from the current administration?
Yeah, I mean, I think there's no, there's no way around that there will be reduced federal funding. I think that was very clear in what Amir put forth this morning, not only in the actual core, the core Medicaid program, but also just very explicitly in the waiver. CMS has already indicated that they'll discontinue DSHP, which is a nature of achieving additional federal match. So that requires us to think differently. We're going to have to be innovative, and we welcome you all in joining us in that effort. I think there are some of these where you'll see these services exist in a way that the viability of them remains present, but the influx of funds won't be, just simply won't be the same. And also it doesn't have to be the same in that regard either, right? We intentionally put forth a very large amount of money to build the complex infrastructure that Selena and Emily were talking about. That's you don't have to keep doing that. There's a reason that you invest to begin with and continue on. Some of the workforce programs, we'd love for that to continue forever. If CMS doesn't fund it, you still have the lasting impact of those people that you were able to train during the time that we had available to us.
I think this is also, why we have social care networks, right? Because they can get into the nuance of like risk-based or non-risk-based, right? When we're looking at, new models of payment. But for community-based organizations, this shouldn't look or feel any different, right? You're getting paid for the services that you provide. And so I think when we're saying that, this will kind of look and feel, the same, our goal is, not to, disturb the infrastructure that's being built, that we're building this infrastructure with a purpose and with the purpose of sustainability, and that social care networks will be able to kind of sustain these models through the next waiver.
And I'll just say, if you're a Medicaid wonk like me and Amanda offers up the opportunity to brainstorm with you about innovative state fund financing mechanisms on how we're going to get the state share in the next waiver, there's nothing more fun than brainstorming about innovative waiver financing mechanisms. So just know that sounded like an offer to me, and I think we'd be happy to be part of that. So as we get ready to move actually to questions, would love just each of your take on kind of one kind of insight or lesson from the last 19 months of implementation that really is shaping your own thinking about how this waiver is going to evolve as it finishes out its second half, but also then how that will inform what you just talked about in terms of the future labor waivers.
I'll jump in to start. And I'd say what I've learned and taken away is the strength of this community. There are brilliant ideas out there. There are so many examples of really creative things happening that you wouldn't have necessarily thought of. We've seen plans and providers partner to host baby showers to be able to reach reach pregnant women as early in pregnancy as possible, or spin up a van to go deliver social care screenings in an area where they wouldn't have access otherwise. And so I think the creativity of this community is key. And to that end, if I could plug, if you've not connected with your social care network yet, please do so. They're in the room today. But in addition to that, the waiver team here has built a ton of great resources for everybody in this room to be able to tap into. So if you've not gone and checked out our website yet, where we've got a couple of great provider webinars, some great provider guides on how you can engage and what pathways may be the right fit for you. It's a nice way to supplement the connections that you can make today in talking with the social care networks who are here.
So before you guys go, let me take that opportunity to build on what Oksiri said this morning. Part of what we try and do here at this conference each year is create community. And to Amanda's point, I'd like all the folks that are from an SCN or a WIO to stand up so that folks can look around and identify the people that you need to be talking to. I know there's more. Yeah, exactly. Uh-huh.
Here.
So yes, let's all thank them. But these are the people that we all need to be connecting with. They're on the ground, putting these services in place. And to Amanda's point, we want to build communities so that we can all work together with the folks doing the work on the ground to improve the lives of our Medicaid members. Sorry to insert that there, but it just felt.
No, absolutely. No, that's great. I mean, and to build a little bit onto what Amanda was saying, sort of there's different ways to partner as well. And that sort of creativity has been great in terms of, maybe a provider or a CBO doesn't want to do the screening and navigation themselves. So the SCNs are embedding navigators within, an ER or urgent care, or, we've even heard of within school clinics and school districts and in courts. And, it's been really incredible to see that creativity and that really that significant effort to meet people where they are. One wonky thing that maybe is only important to me that I learned is I never want to do a mid demonstration period amendment of this magnitude again if we can avoid it. But that's just me.
Just one thing.
You can do two.
in the beginning, there was so much of the train track being laid down, right? We have a 300-page manual that the social care networks have run with, and or it might be over 300 pages now, but available on our website. And so, it was a lot of, in the beginning of like really partnering together and figuring out like what works, what are the challenges, how do we overcome these challenges together, and like, being like true partners, right? And I really appreciate the social care networks and how much like hard work and dedication they've put into growing their networks to this point, because now they do, like I mentioned, have coverage of all the HRSN services, not medical respite, yes, but that's coming soon. And I just want to say there's an opportunity here, right? We shouldn't wait until the next waiver or wait and see what happens. Like, we have to take this opportunity and serve as many Medicaid members as possible. And I think this is an exciting time because we now have this train track, right? And we can now are doing outreach to members, right? The social care networks are now doing the marketing, and they're looking for more partners to onboard, to do screenings, to provide more services, to outreach to Medicaid members. And I think a lot of the folks in this room have that ability to make those connections to Medicaid members and make this program successful. So I think lesson learned is, 300-page manuals are fun for everybody, but the real work is the boots on the ground, and the work that the social care networks are doing in their communities with their partners. And it can only be successful if everyone participates.
Absolutely. And just if I can, on just to piggyback off of something Amanda said earlier, we recognize that, we're doing all of this very quickly, and feedback is so important to all of this. We put out surveys, we constantly are meeting with groups. So please, we have shared mailboxes that you can send thoughts and comments and questions to. So please don't hesitate to reach out to us, because we really want to make this work, and we really want to help make connections and to make this the best program that it can be.
Great. I would encourage folks to come up to the mics with your questions. And while you're doing that, I'll kick off a couple from the web. Thinking about specific partnerships, what are the roles and responsibilities and collaboration efforts with local departments of health across New York, and specifically thinking about, obviously, our august Department of Health here in New York City?
Yeah, Emily, I know you've spent a lot of time working, but I think I maybe clarify one point before Emily jumps in with just practically how it works. One of the federal rules here is that it's very important that there not be supplantation of funding with the waiver. So that so some of the local departments of health may feel the challenges of that in the day-to-day, and as we keep those rules, that's really clear. But there's been a tremendous amount of outreach and effort to enhance what's already ongoing.
Yeah, I want to give kudos again to the social care networks, because they've done a really good job of bringing them in as partners, of meeting with the different local departments and making sure that they feel a part of things, that they understand what the workflows are, what the services that are provided by the waiver are compared to what can be provided by a local district. So again, kudos to the social care networks, because they had those conversations early on, and I know they continue them.
Laura? Oh, sorry. George first.
Yeah, George Hulse, Emblem Health. I know I speak for everyone when I say thank you so much for the work that you do. We're most certainly very grateful for the work that you do. The federal government, prior to this, gave us, of course, money for DSRIP, and that money went primarily through the hospital systems, with the exception of Somos, a large IPA that got a large chunk of that money also. And now we're doing even better with the 1115 waiver and going through community-based organizations that really have a direct connection to the ground. If the federal government is kind enough to us again and gives us a large chunk of money to improve health, what would be your wish list? Where would you like that money to come, and where would you like that money to go?
Great question, George. And if only we were to have that problem. I think, we're big on data-driven decision-making. And so what's fortunate is that I don't imagine that we will have that challenge in the next couple of years here. So we'll have ample time to see the actual progress and true impact that we've had to be able to evaluate and figure out the most impactful path forward. But I can say that we're very pleased with the level of immediate penetration and ability and outreach that this direction has taken within the waiver to be able to build a very rapid infrastructure within the social care networks. Plenty of room to go, lots of work left to do on that front, but be able to reach members and the community in a way that hasn't been available before. So we're grateful for that and would love to have the opportunity to invest again.
I would just add really quick, something we did in this, and we didn't really get into it before, but the social care networks, in addition to, the training and onboarding of community-based organizations, are also providing direct funds to community-based organizations that are signing onto their network to help with like equipment and staffing and infrastructure. And I think that's a best practice that we learned, kind of early on is, folks, in order to really meaningfully participate in this work, need that capacity funding. And so I would continue that, I guess. But,
and was a lesson that we learned from DISRIP, right? Like in terms of the CBO's ability to participate in these Medicaid programs, it's not their traditional space. And so it's a steep learning curve, and even in terms of billing and systems, et cetera. So that was a really
going
important.
from like a grant focus to rates. Yeah, definitely.
Dr. Diaz?
Hi there, I'm Chanel. I'm a primary care physician here in New York City. And my statement first is, we know that health-related social needs will only increase in coming years, given the policy changes that we're seeing. And the federal government is excluding immigrant communities with near surgical precision from many services and programs that are essential for life. My question, and going back to the point of public health accountability, is what is the state doing in preparation to meet the needs of mixed status and immigrant families who are going to be excluded, who are going to be losing coverage and excluded from many services? How are we going to ensure that we can still meet their needs?
It's such an important point and such an important question. I think some of this, frankly, we're still figuring out. I think you've got a commitment from the state to do everything that we can to care for the most vulnerable population, but the federal changes have been abrupt and continue to evolve. So I think we comparably need to continue to evolve. What we can do and what we have done and will continue to do is invest in all of the channels that we're permitted to federally as heavily as we can. And building up that infrastructure does free up and enable some of these organizations to continue the on-the-ground important work that they do surrounding the channels that we've been solidifying. So while if we may not be able to pay for something via Medicaid funds, for example, that doesn't mean that those services can't be provided. And we'd love to do what we can to support them. And I think you'll continue to see some investment and activity from us as we think about the ways to appropriately tackle that.
Laura?
Hello, Laura Castle. I'm the coordinator of Medicaid Matters New York. Thank you for the discussion, and I have a cheering section. Thank you for the discussion and for all of the work that you do. I have many, many questions. I'm hoping perhaps the moderator would grant me two, but I'll start with one. I'm wondering and hoping if you could say a little bit more about the renewal application. Wonderful to hear that you're going to be applying for more in the area of health-related social needs. I'd love to hear about, maybe a little bit more about your overall approach. Are you approaching this perhaps as we shoot for the moon and hope for the best and maybe we'll get the stars? Is it more of a kind of realistic approach based on the current administration? And maybe if you could tell us a little bit more about what you might be contemplating to get in there while in the application while you draft it.
Yeah. I can start with the theory, and then Selena, you can talk a little bit more about tactically. I'd say our approach has been rapidly evolving because, as you could imagine, like, there's some of these changes we just didn't see coming. So we may have been in one camp, and I think we're actively debating what the right strategy, the most successful strategy is to get through federally. So I actually can't tell you if we're going to land in the let's be super realistic and as narrow as possible, or let's shoot for everything and see where we can go, because it's a really difficult landscape to navigate right now, and we're actively debating and welcome input from this group in what you think may be most successful in that regard. Selena, you want to talk a little more about specifically what we're digging into?
Sure. I mean, I guess I would say it's probably a combination of both, right? Like being practical in terms of, not going for things we know that they're going to absolutely say no to, but also trying to continue things or have things approved as we want to see them, as opposed to how we think they will want us to see them. I don't think that would put us in a great place tactically. But I think, like Amanda said, things are rapidly changing. And so we're working with our state partners to figure out, what is the right path forward for us as a state? What are our priorities? And working from there.
I'll give you a second.
Thank you. So my second question is piggybacking on the offers that you've made for involvement and engagement and brainstorming, as Chad put it. As Selena, as you said, you have meetings all the time with a lot of different groups, and you have email inboxes, and you all, do the work that you do in the best ways that you can, involving stakeholders. But I wonder if you could talk more about what you're planning. There are prescribed comment periods, but what does stakeholder engagement really look like in this process beyond meeting with you and emails? Because we know that there are so many people inside and outside the consumer advocacy community that would love to be engaged, that have innovative ideas, that have, we've got lots of ideas about lots of different things, we and others. And I wonder if you could talk a little bit more about what engagement might look like in the next few months, and how you could, really effectively include more people into the process.
Yeah, I think we've got, like you said, we have some formal channels, and Selena, you can maybe speak to the formal channels we've got available. But there are many people who would like to have input, and very few of us. And so sometimes those channels are like, can you provide us with a summary of the idea, and we can hold time to talk through it more frequently, or can we convene a session on a topic? I think what we're having to do, because of the volume of changes, is get much more tactical in narrowing down. Please don't come to us with a request for an investment of $10 billion in the next waiver for a particular issue. Like, that's not realistic, and that's not going to be a productive use of anyone's time. But if you've got a creative idea on a cost neutral change that you think can really, that's creative and innovative and could be adopted, we'd love to spend time to hear more. So I think there's just going to be some of that practical reality of how do we make the most of limited time and resources and many competing demands. You'll see that the waiver team is also heavily involved in the changes that Amir discussed this morning with HR 1. And so it's just it's a sort of attack from all directions here.
Yeah, I would say stakeholder engagement and transparency is such an important part of this process, from development to actually having a final draft submitted to CMS. As Amanda was alluding to, we do have the formal channels of public comment periods, and we really encourage folks to either send us written comments. We read all of them. We track all of them. We
talk about all of them.
Talk about all of them. I think in our last waiver, we got nearly 800 comments, or waiver renewal rather for NYHER. I think we had around 500 comments, and we do go through every single one. And please come to our public hearings. We will have 2 of them. They will be virtual. We'll post information about it on our website. We are revamping our 1115 website to make it more accessible. So, and to make it easier to find upcoming events and things like that, it'll go out through our MRT listserv. It'll be posted in the state register, the dates and the ways to join, all of that. But we welcome people to come testify there or to submit written comments, and that's what helps us develop these things, make them better. We don't think of everything, and so, and like you said, there's a ton of people out there with very creative ideas, so we'd love to hear them.
Thank you. And thank you, Chad.
Hi, David Menashe, Montefiore Health System. Thank you very much for coming. So I have a money question for you guys. So, and tell me if I'm wrong in my thinking. So I'm thinking that there's a major risk that, when the time comes and this period expires, that we don't get an extension, right? Is that, I don't know if that's a real risk or not a real risk, but I guess my question would be, is there anything we could collectively do to make sure that whatever money's there gets kind of distributed and out before the thing expires, so that we don't end up paying anything back, right? To Washington, we would never want to do that, right? I mean,
Well, what I'll say is, so our 1115 waiver, remember, it governs our entire managed care system. So we'll have an 1115 waiver. What that looks like, is what's up for discussion. But yes, please connect with your social care networks, deliver services to members right now. You don't get to keep this money. It will go away. And there's a lot to spend. The infrastructure's there. There's no reason why you wouldn't. If you're a managed care organization, this is an immediate way to deliver, to lower your medical costs without paying anything. All you need to do is connect your member to this organization now. If you're a hospital system, find a way to embed a navigator in your waiting room so that you can have people screened and connected right away. I think you heard from Emily, we've got nearly 1,000 CBOs connected into the system, ready to deliver services. They are delivering services. There's obviously a natural throttle of how you can't deliver a service to someone you don't know about. And so come join us in participating now as quickly as you can at as large a scale as possible, because we do have very little time left with this.
Absolutely. I know. I feel like you hardly hear from the state, please come let us pay you for things. And, particularly the screenings and referrals and navigation are things that, healthcare providers and others are doing today. And we want to reimburse you for them. We want the connection to the social care networks. And I'll make a similar plea for our career pathways training program. Please encourage folks to apply, connect with your workforce investment organizations, encourage folks to apply for our student loan repayment program. That's how we get the funds out the door.
thank you.
Great. Well, I may have the last question, but I want to ask one from online before we get to that. Interesting question, thinking about kind of the future and sustainability, and thinking about whether there are potential kind of spillover effects from the waiver services, maybe to non-Medicaid populations, to communities as a whole, that might help us make a case for the value of these services in a way that might be more saleable to current administration folks. And should we be looking for those spillover effects?
Yeah, I think you heard us talk a little bit about that earlier. If you've got CBOs who now have access to technology and resources they didn't have access to before, access to a sustainable funding source for a dedicated population that they may have been providing services to at no cost previously, or with no revenue previously, there's a natural free up of resources. The spillover effect is really interesting when you think about how to drive that home. I think New York City does such a great job with the neighborhood evaluation, and to be able to really like dig in and see how the clinical outcomes of a given neighborhood have shifted over time and what the effect of that has been. So I love the idea of what if we overlay and just see what the neighborhood looks like. You heard us. We started to do some of this as we've contemplated some of the other aspects of the waiver, like the ahead model that's shifted some as part of the federal changes. But I think we'd welcome those examples if you see them coming through. If you've got in particular a call out of if you've got a zip code or a neighborhood where you think, wow, this has had a tremendous impact, and you can see the year-over-year change, or the before and after effect, call it out to us. We'd love to be able to really bring that home and highlight that effect across the board.
Great. Ami.
Hi, Emily. Hi, Selena. Hi, Amanda. My question is a little bit different, but I would be remiss if I did not bring it up because I've been thinking about it since July 24th. So the executive order of criminalizing people who are homeless and people with serious mental illness. And I know, like, I run a health home, I run an IPA, a behavioral health IPA, and now an SCN. And when that executive order came down, the SCN is supposed to impact homelessness. Like we're trying to impact or reduce homelessness, right? The health home is trying to work with people with serious mental illness. Like we built this infrastructure in New York State. I was just wondering if you have initial thoughts about the impact that this is going to have on states, because the funding is going to have to come from states, because it's requesting to institutionalize these people, right? They're taking them off the streets, putting them in other institutions. So I was just wondering if you have any initial thoughts. It's a horrible executive order, and I just feel that we get slammed every week, yet again and again and again. And so I don't know if you have any initial reactions, but I've been thinking about this, and as I said, I would be remiss if we didn't raise this today.
Sorry, do you mind? Homelessness is near and dear to my heart. Like it's a huge passion of mine, and housing is a huge passion of mine. So I appreciate that question. I think you're right. We keep getting slammed, right? And it makes us freeze a little bit every time something new comes down. But we can't freeze, right? We have to seize this opportunity we have. And social care networks have these housing services where we can pay for, up to a year of housing navigation. We can engage in pre-tenancy and tenancy services, which are huge at sustaining housing. And our housing evaluation for Medicaid Redesign Team Supportive Housing Initiative, that was a mouthful, sorry. We found that the longer someone's housed, the better health outcomes and the better longer life the person has. So the housing research is there. It's on our website if you guys want to check that out. But the social care networks are poised with these services that are approved and payable through Medicaid, right, to help this population that's being attacked. And so I think, again, we keep, it's blast after blast of these policy decisions. But instead of freezing, I think we do need to seize this opportunity that we have and help as many homeless Medicaid members as we can, right? Make sure they're enrolled in Medicaid managed care, get them the services that they need. Let's find them housing. The social care networks are now connected to the Medicaid Redesign Team Supportive Housing Initiative programs, right? We got an increase in funding to allow for that referral from social care networks into our housing program. And so I think we have to take advantage and capitalize on this. And again, help as many people as we can, and just kind of I like to say, cancel out the noise, right? And keep our eyes on the mission of helping Medicaid members that are most vulnerable.
Yeah. And not only connecting them to the housing services, right, but also to behavioral health services, substance use disorder services, health services, whatever they may need. That was part of the design that we envisioned with the social care networks, that they could help make those connections when they come across people that might be disengaged with the traditional healthcare system.
And we can commit to you that if there's a change in Medicaid rules, we will tell you. So there's a truckload of noise coming from all of the executive orders, many of them done without an appropriate legal pathway or the appropriate rulemaking channel. That doesn't mean that we have to change our behavior just because there's a voice that declares it so. Like we will tell you when the Medicaid rules change and you need to do something different according to New York State Medicaid.
Great. Well, I think that is a perfect place to end. I don't think you guys know just how lucky we are as Medicaid stakeholders in New York, as a state itself of New York, and as Medicaid members served by these people, to have three people as amazing as this working tirelessly every day to improve the lives of the Medicaid members we all try and serve. So please join me in a thunderous round of applause for our panel.